Hello, I am Adashi, Professor of Medical Science at Brown University and host of Medscape One-on-One. Joining me today is Dr. Joe Antos, the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. Welcome.
Thank you.
We are truly privileged to have you with us here today.
Well, I appreciate the opportunity.
Beginning with the obvious, how would you sum up, best one can, the recent three-day hearings of the Supreme Court on the very future of the Affordable Care Act?
Well, I have to say that the best single word is uncertain. We do know that oral arguments sometimes, not all the time, I suspect not so much in this case, but oftentimes the oral argument stage is really put on to test the various sides on the issue, not necessarily reveal what the justices actually have in mind. I don't think that was the case generally in this for this momentous decision that's about to be made. For example, Justice Kennedy, who is often considered to be the swing vote, made an observation on the second day of argument about the mandate, raising the concern about changing the fundamental relationship between the people and the government. That had to be something that was from the heart, from the mind. It doesn't tell you which way he is leaning, but it indicates a concern.
It is obviously impossible to predict the outcome, but in your mind as a seasoned observer of healthcare in this nation, you must have formulated in your own mind certain scenarios as to how this might go. Could you share with us just a few thoughts about potential directions that this might take depending on potential outcomes?
Sure. So we can dispose of the two extremes right off the bat. If the Supreme Court basically says everything is all right, then what happens in the future depends on the election. If President Obama is reelected, then things will move along, I won't say according to the plan laid out in the Affordable Care Act, because the timing is too short, the expectations are too great, things will change. That's true for all legislation, but this is especially the case. The other possibility, which I think is not at all likely, I think there is a possibility, by the way, that the Supreme Court could just say everything is fine. I don't think it's likely that the Supreme Court would throw the whole law out. But to me, the most likely possibilities are to remove the mandate or to remove Title I. Title I is the part of the law that deals with insurance for the under 65 population. And obviously, the mandate has zero impact on the Medicare program, zero impact on the Medicaid program. It really is a law or a provision that is required of people between the ages of 0 and 64. Now, if the mandate goes and everything else remains as it is, then we're going to have an interesting and difficult time. The insurance industry would like you to believe, and they're not unjustified in this, that without, I'm going to say a mandate, not the mandate, without a mandate, the insurance market will collapse. The other provisions that make this probable without some kind of mandate or some other restriction or encouragement for people to buy insurance, the main problem is the two words, guaranteed issue and community rating. Guaranteed issue, of course, means that if you want insurance, it has to be offered to you, you can buy it. And you can buy it without any consideration for your current physical condition. So pre-existing conditions would not count against you. The community rating part of it has to do with what insurers can charge. And in that case, it's really more a matter of can they charge more for people who will predictably use more benefits? And the answer is no. So if you can't charge more as a businessman, if you can't charge more to people who use your services more, then that's not a smart business model. That isn't going to work. And the insurers are right. Without, again, some strong encouragement, what you'll have is, over time, you'll have people realizing that they can buy insurance anytime. So think about young people. Young people who don't like to buy insurance now anyway, they're paying off their cars, they're paying off school loans, and lately they don't have jobs, so they don't have the money anyway. But they're not inclined, they're healthy. They're not inclined to buy insurance. They don't think about it. My own children went through that phase. And so they're not going to buy insurance unless there's some real pressure on them to do so. The fact is that the mandate doesn't apply that pressure. The politicians who support the mandate want you to believe that the word mandate by itself is enough. Well, it's not true, of course. There are no teeth in it. In 2014, the penalty is a whopping $95. It will rise to the stratospheric height of $650 or $700, somewhere in there. Well, that's a year. How does that compare to thousands of dollars for the cost of health insurance? If you're young, healthy, and know you can put it off, why wouldn't you? And the mandate has no other teeth in it either. There's no penalty if you don't buy insurance right away at the first opportunity and you sign up for it a couple years later. Your premiums cannot be increased because you failed to follow through as the law wanted you to. If you drop your insurance for a while and for reasons that have nothing to do with low income, lost my job, that's a legitimate reason. But no real reason other than, well, I don't feel like paying for it this year. And then you sign up again, your premium doesn't go up. Well, those aren't sensible restrictions on people.
If I hear you correctly, and I may be putting words in your mouth, but you might be saying that if, in fact, the mandate were to go and Title I with it, that may not be the end of the world because that provision may never have been optimized, shall we say, in terms of the appropriate economic incentives and disincentives that would have, in fact, enforced the mandate. In which case, whoever ends up with the post-Supreme Court world would have to deal with the issue, in a sense, almost from scratch, whoever that president may be.
Exactly, including President Obama.
Yes.
You know, one of the big legal arguments, has to do with so-called severability. And one of the peculiar aspects of this law, it's unusual because virtually every law that is passed by Congress has a passage that says if any individual provision in this body of law is declared unconstitutional or made ineffective in some way, the rest of it stands. That was in the Senate Finance version of the law. That was taken out of this version that the Senate passed. And I think the reason for that was that people, not understanding what their own provision did, came to the conclusion that you couldn't have a guaranteed issue and community rating, these insurance regulations, without a mandate, believing incorrectly that this was going to be effective.
Interesting. Speaking of the ACA, which we can still do for the next 2 months, I suppose, with impunity, after which time, who knows. There has been a recent debate, or perhaps a reigniting of an older debate, of how much will the bill cost? Will it live within its projected budget? Will it cost less? Or, as the CBO has recently suggested, may in fact cost more? As someone who worked at the CBO at some point and continues to advise the CBO at this time, where do you see the issues? It's hard for the non-informed provider out there to firmly distinguish between these three different scenarios.
Sure.
Where is the truth to the extent that such can be established?
Well, I'm not sure the truth can be established, but the speculation certainly can be.
Yes.
So in terms of budget scoring, one thing that everyone should keep in mind, which is, and I say this with all due respect to the CBO, I'm a graduate, as you say, and I enjoyed working there, and I think that they fulfill a very important place in the legislative process. But the fact is that they're not fortune tellers. Economists, I'm an economist. I'm not a fortune teller either. If I were, I wouldn't be sitting here talking with you. I'd be sitting on the beach, in my billion-dollar mansion. So the fact is that economists are not necessarily very good at projecting the costs of especially complicated legislation as this is. There are a lot of things in this legislation that have never been tried before, either individually or at least in one full package. And so I think this whole question of what CBO's score was several years ago and what's happening in the future is somewhat sterile discussion. I think what's much more interesting is how will the health sector, assuming that this law continues largely intact, how will the health sector react? That really determines not just the real cost, but it also determines what happens to patients, physicians, and other providers.
Well said. I suppose another way of looking at this is to say that such exclamations or reports are probably then subjected to political ends by whoever the interested party may be, but as you say, really does not serve a terribly constructive purpose.
I mean, we should be concerned about the cost of anything, and if we see costs in any program rising beyond what the social and political consensus would have, then we would hope that Congress would take some action. We would hope. We would be disappointed in most cases.
Turning now to another perennial challenge, and that is the financing of Medicare,
Yes.
about which you have written extensively over the years. It seems appropriate to say that the future vision of the financing of Medicare is articulated on the one hand by the Affordable Care Act and the administration, and on the other hand by the two budgets, I suppose, and the two proposals by Congressman Paul Ryan last year and this year, those being very different outlooks on how the financial viability of the Medicare Trust could in fact be maintained. In the interest of our viewers, could you say a few words about how those two visions compare and contrast, the strengths and weaknesses that you see in either, and to the extent that you can, and I know it's difficult, take us a little bit through the process by which some of this may ultimately resolve.
Thank you. It's a great series of questions. How many hours do we have?
Understood.
So let's first consider the president's position on Medicare, which is really contained in the Affordable Care Act. He put out a budget this year. All presidents put out a budget every single year. Budget, by the way, in this case means for every president a political document. It does not mean a household budget. It doesn't mean we're going to live by it. what we live by is what Congress ultimately passes. So the budget really is a blueprint.
It's a request.
It's a request.
Needs to be approved by the Congress.
Except that it never is. I don't believe in the at least the modern history of budgeting that any president's budget has ever been simply taken as a whole, and that's a completely unrealistic prospect. So what does the president have in mind? Well, he has in mind the same kind of policies that we've had in Medicare for decades, really, since almost the beginning, which is if you see Medicare spending rising too rapidly, then we'll see Congress take cuts in provider payment rates. Now, there are some new wrinkles, of course, but the new wrinkles aren't very well worked out, and they're going to take some time. And I think a lot of these new wrinkles make a lot of sense to me. I mean, the idea, for example, of bundled payment, it's a great concept. I suspect that right now, the viewers are saying, many of them are saying, what do you mean it's a great concept? And what I mean is it isn't worked out. And there are all sorts of problems. But the idea of paying a relatively fixed amount for, say, all the things that go on in the hospital, including physician services, which we don't now have, could potentially encourage hospitals and doctors to cooperate more thoroughly and eliminate some things that don't need to be done in under the rubric of greater efficiency. There's another risk, however, and the other risk, which is shared by really any way you cut the budget. And that is, especially cutting prices. When you cut prices, what do you get? Well, potentially, if you cut deep enough, you will discourage providers from participating in the program. Now, politicians want us to believe that that would never happen. But if we were really talking about implementing the cuts in the Affordable Care Act, we're talking about driving Medicare payment rates down very quickly to Medicaid rates and never rising above that. And the only reason they stopped at Medicaid rates is there's a law that says that Medicare can't pay below Medicaid. So is that a practical way to proceed? I don't believe the answer to that is yes. I think we've seen over time with the sustainable growth rate for physicians that if there's the prospect of taking really huge cuts in provider payments, Congress is going to blink. Congress is going to say, no, that's too much. They've done that for 8 or 9 years in a row with the sustainable growth rate. There's no prospect that they will fail this year to kick that can down the road, but there's also very little prospect that they'll resolve that problem anytime soon. So that's basically it. And people talk about the Independent Payment Advisory Board, the IPAB. We could argue a little bit among friends about whether that is really a new thing or not. But the fact is that their tool is reducing payments to providers. That's largely it. Okay, so the other alternative, as articulated best by Paul Ryan, but in fact it's not a new idea. It's been in the health sector for many, many years. It's now called premium support. It's basically putting Medicare on a budget. It's another way to bring Medicare spending, the growth rate in Medicare spending under control, to reduce the rate of growth of spending. People criticize it, arguing that, I believe incorrectly, that this will impose huge costs on your mother. Well, most mothers live on fixed incomes. It was true in 1965. It's true today. The vast majority of people who are over 65 are living on Social Security. They may have a pension, but there's no prospect that they're going to get a sudden increase in payments just because their costs go up. And so what does premium support really do? Does it really force the senior citizens to pay another $6,000 for Medicare? Well, that's one interpretation, but a more sensible interpretation is that Our parents don't have the $6,000. And what it really is a shot across the bow at all providers saying, not, we know exactly which payment rates to cut. We know exactly where to put restrictions on the use of services, but rather, here's a budget. And guess what? You won't be going back to your real customers, your patients, and getting thousands of dollars or more because they don't have it. So there's a difference in philosophy. One, the president's approach is a more centralized approach. It's the approach we have used since 1966. It hasn't worked very well. The other one says, essentially, let's put the program on a budget, but let's not try to guess what the price of specialist services should be compared to specialist physician services compared to home health, to make the most ridiculous comparison possible. Let's not try to figure that out. Let's let the health plans work that out. Let's have the negotiation continue between the patient and the physician about what should happen. And what everybody says, both Democrats and Republicans, let's give everybody, patients and physicians, better information about what they're doing, what it costs, and what the consequences might be.
Thank you. Is there any prospect that some of this will be resolved before the election or after the Supreme Court has spoken or at any other point in the foreseeable future?
Well, I do think that we will see some resolutions. Obviously, the Supreme Court will settle some minds about certain things. If under what I think are the two most likely scenarios, either throwing out the mandate or throwing out all of the insurance provisions, all the under 65 insurance provisions, in theory, that would throw it back to Congress to figure out what they really wanted to do. Unfortunately, as I think everyone knows, the political climate has deteriorated, not just over the last 4 years, but it is steadily deteriorated over the last decade. And so I think it's highly unlikely without some other force, and I'm about to say what that other force is, for Congress to reach agreement on resolving the problems associated with the Affordable Care Act or any of its other problems. Okay, so what is that other force? Well, the answer is the debt limit. You may remember that last August.
A contentious summer.
And in August, they passed something called the Budget Control Act. The word control was a misnomer. Like most things that Congress passes, there's usually one word that's wrong. That's the word that was wrong. And the net result of that was that there was supposed to be a deal made between cutting spending and raising the debt limit, raising the government's ability to borrow. We need to be able to borrow. The Medicare program needs to be able to borrow. Basically, the government just cannot operate solely on the funds that come in through taxes. And this is not just an issue because of the continued slow economy. It's a bigger issue, right, but it's always been the case. So we need to be able to borrow to keep our programs going. And so the deal was raise the debt limit, cut the spending. What happened? The debt limit went up almost immediately. The spending cut remains to be seen. And it will, if it really happens, it will space itself out over the next 9 years or so. Well, if we're lucky, the debt limit will not be reached again until sometime in early next year. Some predictions have it that we're actually going to bang into this thing again, possibly around election time. If that's the case, I have no doubt that Congress will do what they've done with physician payment. They'll pass something in the lame duck session that buys them a few months so that they can actually negotiate with the new Congress, not the old Congress, and the new president. And by the new president, I also include President Obama. A second term makes you a new president. There's no doubt about it. Your perspectives change. So here we will have this enormous fiscal pressure, which cannot be delayed, will have to be dealt with. Unlike last year, the fiscal hawks, which are both Democrats and Republicans, will realize making a deal where we raise the debt limit here and wait a long time for cuts just doesn't work out very well from the fiscal prudence standpoint. And so I think what will happen will be a really brutal battle. The net result will be that if it's President Obama, he will have to find very large savings. They'll have to be real. And I think the Affordable Care Act, parts of the Affordable Care Act, are clearly going to be on the chopping block. And he will say publicly that he's against it, but privately he will make a deal. And here's the reason. Not only does he need the cuts to raise the debt limit, but also there's practical reality. Even the states that really want to put exchanges into place are having trouble. And they need to be in place, not in 2014, they need to be in place and fully operable by June of 2013. Mm-hmm. Well, the regulations that the federal government has to issue that give the insurers the guidance as to what they can offer and what they can't offer haven't been issued yet. The essential benefits package, well, that was a general vague guidance. That's not a regulation. Mm-hmm. That regulation has to be finalized because insurers have a lot to lose, both financially and legally, if they accidentally misinterpret the intention of the administration and move in some direction that, oh, we didn't mean that, and the regulation comes out too late to make a change. So basically what we have here is the usual problem in Washington. Anything complicated, they say, oh, we want it right away. But of course, reality eventually intrudes. I think reality will intrude, and I think the president would reluctantly accept two changes. One is delay 2014 to 2015, which is really probably not enough time, but it helps.
For the exchanges.
For example. Mm-hmm. And then reduce the Medicaid expansion from 133% of poverty to 100% of poverty. The states all said they could live with that. Mm-hmm. That actually saves money in a budget sense. And then the subsidies in the exchanges, I could see those being pared back as well. So that would be a very sensible, I think, package of compromises that second-term President Obama could make if he has to, if the pressure is on, and I think it will be.
If nothing else, I hear echoes of the grand bargain all over again.
Exactly.
Before we conclude, perhaps I will force you yet again into the fortune teller uncomfortable position by asking you, to the extent that you can tell, what would healthcare look like under a President Romney?
Well, I don't.
And of course, we were going to have to allow for the uncertainty of the Supreme Court action. But
sure.
With that as a given, how do you think about healthcare under President Romney?
Well, one of the things he's said is that he believes in state experimentation. Of course, he's proven it in Massachusetts. And I think that if he were elected, that would also presuppose that the Republicans would hold their majority in the House, and they'll get a few more seats in the Senate. They may have the majority in the Senate under that scenario. I don't think anyone will have 60 votes, so the Senate will still be a tough call for anybody. And but the Affordable Care Act did something. It's already done it, right? And it's not so much that the government did it, it opened sort of the spigot. And so health plans, provider groups, employers, they've all taken some sort of an action. The states, many of the states have as well. And a lot of those things, you're not going to put the genie back in the bottle. Mm-hmm. And so although Mitt Romney, for good, sound political reasons, is saying he's going to repeal it on day one, the reality is that a lot of what we see having already transpired will continue to go on, but a lot of the big spending parts of it will be rethought. It doesn't mean that we won't have big spending. Of course we will. We have it now, even before 2014. But I think that will be rethought, and there will be an attempt to reform the private insurance market in sensible ways. I think that would mean not eliminating insurance underwriting altogether, which is what the insurance reforms did under the Affordable Care Act. I think what it means is that you have some reasonable regulation so that underwriting actually works in a positive way. Penalize people by making them pay a higher premium if they don't, without good reason, maintain their coverage. That's the most sensible thing in the world. Democratic analysts, and Republican analysts, so basically those who aren't involved with campaigns, have basically agreed that that would make sense if we would just do it. So there are a bunch of those kinds of changes that would occur. I strongly suspect that the Medicaid expansion to 100% of poverty would probably stick. I'm certain that big cuts in provider payments in Medicare will stick because, bluntly, we don't have another fiscal tool. But under Romney, we would see over the course of his first 4 years whether we could make some progress politically on the Hill and socially in terms of people understanding what their alternatives really are. They're not great in the Medicare program, but I could see us making considerable headway towards a sensible premium support style program.
If nothing else, President Romney and candidate Romney are not one and the same,
Right.
as has been true for many of his predecessors. If I may close on a personal note, I have made the observation that you started your career in the Department of Labor. And thereafter, of course, you dedicated much of your energies to the study of healthcare economics, healthcare policy, and related matters. If you could perhaps trace for our viewers the seminal events that were responsible for this career choice and made you obviously interested in the long term in what is probably one of the signature issues of our time.
Well, of course, when I started my career, there was no such thing as health economics. Health policy was not an issue that you studied at any level, undergraduate or graduate. It really didn't exist as an academic discipline. And I think the first health economists were, in fact, labor economists. I like to think of us as having been saved. It's a religious conversion almost. But in fact, I was in the Office of Management and Budget. I had the opportunity to move over, across the street, to the President's Council of Economic Advisors.
This is during which administration?
This was in the Reagan administration.
Reagan administration.
I'm not a political appointee. I've never been a political appointee. And
who was Reagan's director of the Office of Management and Budget?
David Stockman.
David Stockman.
Who was, in my opinion, he was a great director. His goal was to know more about the little details of the budget than the budget examiners who studied them on a daily basis, and he often beat them at the intellectual game. Kept everybody on their toes. But I was invited to go over to the Council of Economic Advisors. I went over there during what turned out to be August vacation. I was the only one in the office. The phone rang, and it was someone who introduced me to the concept of catastrophic health insurance and Medicare. And that is really how I got my start. This was someone who eventually became an official in the Department of Health and Human Services, who worked for Dr. Otis Bone, who became secretary towards I think, the second part of Reagan's presidency. And he said, well, I've got this paper. Would you mind reading it? So he sent it to me. I didn't know him. I didn't know Otis Bone from The Man in the Moon. I read the paper, and I called him back, and I said, well, it's a pretty good paper. You have a few issues. And for some reason, my skepticism made an impression, and I just got sucked in more and more and more. You could say that I've had a highly unsuccessful career. I was one of the leaders for the first attempt to add a drug benefit and catastrophic health insurance to Medicare. Both of those failed in the 80s. I argued against the way we pay physicians, lost that one, and so on. It's been quite a career.
We think so, and thank you very much for sharing that with us. On this note, sincere thanks to Dr. Joe Antos and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Eli Adashi.